Hello, this is Haley and Bhakti, and we will be comparing Q angle versus the frontal plane projection angle in determining causes of patellofemoral pain syndrome.
So Q angle is the index of the vector for the combined pull of the patellar tendon and of the extensor mechanisms. The angle is formed by the intersection of two lines that cross at the center of the patella, one going from the ASIS to the center of the patella, and the other going from the anterior tuberosity of the tibia to the center of the patella. It's theorized that the larger the Q angle is, the greater the lateralization pull on the patella, which increases the retropatellar pressure between the lateral facet of the patella and the lateral femoral condyle.
The frontal plane projection angle is a two-dimensional measure of the lower extremity in the frontal plane, and it's used to examine dynamic knee valgus during functional activities. The frontal plane projection angle, or FPPA as I'll call it from here on out, is the angle formed between two lines. A line that runs from the center of the ankle joint through the center of the patella and continuing proximal, and a line that's from the center of the patella through the ASIS.
So in terms of reliability, a systematic review done by Smith, Hunt, and O'Donnell showed that the Q angle had mixed results. The intra-test reliability ranged from an ICC of 0.22 to 0.75, and the inter-test reliability ranged from an ICC of 0.20 to 0.70. They also stated that there is no consensus regarding the number of SEMs that a score must change by to be considered exceeding measurement error. Another study stated that the number of SEMs that would reflect meaningful change on physical impairments is also unknown.
For the frontal plane projection angle, reliability was shown to be good and excellent in quite a few studies, but most notably and most recently was a study done by Ortiz, who studied two different types of FPPA angles. The first FPPA, which is FPPA 1, was your typical measurement of the frontal plane projection angle, whereas your second was taken where the axis was at the ankle joint. So it was a line running through the ankle joint up the tibia to the patella, and then a line running vertical from the center of the ankle joint. Both showed good reliability and good inter and intra-rater reliability, and the FPPA2 actually showed good to excellent inter and intra-related reliability. The only caveat is that the FPP2 method hasn't been studied extensively yet.
In terms of validity, the Q angle has been shown to have mixed results. The same systematic review done by Smith, Hunt, and Donald found that some studies showed poor agreement between the clinical angle and the reference Vader graph, while others showed no statistically significant difference between the two. A study done by Patel found that the idea that high Q angles are related to higher peak valgus angles may not be valid.
In regards to validity of the frontal plane projection angle, a study done by Wilson and Davis showed that only a 30 to 30% correlation between 3D motion capture and the 2D FPPA was found. And in 2016, a study done by Ortiz showed there was poor to moderate correlation of validity between the FPPA and the 3D motion capture. However, all studies, including a study done by MacLean in 2005, stated that although there isn't great correlation between the gold standard, which is that 3D motion capture, and frontal plane projection angle, you can use it as long as you're not trying to make very precise measurements off of the FPPA.
So in terms of responsiveness, there has been no research performed to determine responsiveness data for Q angle. However, due to unclear reliability and validity of Q angle, further research into responsiveness for Q angle could be considered superfluous and unnecessary for the future of determining dynamic valgus.
In regards to the frontal plane projection angle, after an extensive search was done, no research was found to have been conducted to evaluate the responsiveness of this measurement tool yet. However, in a reliability study by Monroe, Harrington, and Carolyn in 2012, SEM values were found, and the authors suggest using the normative values found by Wilson, Ireland, and Davis with the SEM values of the Monroe study to determine improvement in lower extremity kinematics and to determine a potential decrease in injury risk.
So for sensitivity and specificity, there haven't been many research studies done, but one study done by Lin in 2012 did find that the Q angle is more indicative of patellofemoral pain syndrome among patients who had less than normal patellar movement.
And after an extensive search, no sensitivity or specificity studies or values have been conducted on the FPPA measurements.
In terms of feasibility and protocol, due to a lack of standardization of measurement procedures or control of potential confounding variables, it makes it difficult to reproduce in the clinic. Another study stated that Q-angle static measurements presented poor values of discriminatory capability. While it's inexpensive and easy to replicate, mixed results in reliability and validity in multiple studies makes it harder to use in research and in the clinic.
And although there has been little data that supports a high validity of the FPPA compared to the gold standard, reliability has been found to be good to excellent. Many validity studies did, however, support the use of FPPA in a clinical setting to determine the presence of dynamic valgus in regards to patellofemoral pain syndrome and to encourage further screening by a 3D motion system. Many studies also use the Dartfish app, which is a relatively inexpensive app that can be actually downloaded on your phone to measure FPPA during a dynamic task. And finally, as a tool to determine precise measurements, FPPA has not been supported. However, it has been supported to show some correlation with 3D motion system and therefore has been supported in a clinical setting. And finally, although both measurements have been used to identify the presence of biomechanical dysfunction and to explain patellofemoral pain, the research evidence is clear. Frontal plane projection angle has good to excellent reliability. It shows correlation with the gold standard. It's easy and affordable in the clinic, and it's been encouraged to be used to determine lower extremity biomechanical dysfunction. And although it isn't completely valid in terms of the 3D motion system, it has been supported as a clinical method to determining dynamic valgus in patients with patellofemoral pain syndrome.
And these are the references we use throughout the PowerPoint presentation.